Okay, so we're back, and this is a chapter about, or a lecture about urinary tract and reproductive system infections. This will be the last of our survey of body tissue infections. After this, we move on to immunity and all that's involved there. So with that, we're going to start or do this lecture the same format as always. Today we're going to be talking about stages of disease in the urinary system and also the diseases that are associated with reproductive organs. So this would include bacterial, fungal, viral, and protozoan infections. Okay, so your urinary system is comprised of things like your kidneys, your ureters, your urinary bladder, your urethra. And they all have these unidirectional valves that prevent backflow of urine upward. Everything is meant to move downward. And the purpose of this is to shield the kidneys from a lower urinary tract infection. It's a feature of evolution. So, the mucosal membranes that are part of your body, whether that's in your nose or in your vagina or your gastrointestinal tract, any of these things, they tend to be moist and are more supportive of growth than the outer surface of your skin, for example. Now, urine in and of itself is a sterile fluid. However, actually a great growth medium. So organisms can grow there. And so what will happen often is that because the urethra itself, the external tissues there are not sterile, a lot of the time you'll have urine specimens that will be positive potentially because of a failure to do a clean catch urine specimen. So what that entails, especially on the female side of things, is you use a germicidal wipe for the outside tissues of the labia, the vulva, all of this sort of thing. Then you pee midstream. So you start a little, collect in the cup, and then pull the cup out of the way and finish urination, because the start and the stop is when you're most likely to be contaminating with organism. So we want to get a midstream clean catch urine specimen whenever possible. And then you want to try to get those urine specimens to the lab within 20-30 minutes. And if it's going to be longer than that, put the urine in a refrigerator, because again, it can be a great growth medium. And it would be a real shame to diagnose somebody with a urinary tract infection, and as it turns out, they've got just normal flora. So anyway, the body has natural defenses here, in that we have those unidirectional valves, but also the mechanical flushing of urination, of fluid moving from one channel to the next at pretty high force, assists a lot in keeping the urinary tract clean. It effectively washes things out. But there will be certain organisms that can attach really firmly and overcome this. So you can sometimes need to do a urine catch or a specimen collection, especially on those who are unable to do a clean catch specimen. You might have to do a urinary bladder aspirate, which is basically you use a needle to approach the bladder, collect fluid from there, and that will tend to have fewer microbial contaminants. Because again, that's pretty far removed from the urethra and the normal microflora of that mucosa. Okay, so the reproductive system, you've seen this before. This isn't a sex ed class, but they will have some of the same organs as the urinary system, especially on the men's side, because the urinary tract as well as the sexual reproduction organs still take advantage of the penis and the urethra that's contained there. Now we're going to have certain organisms that are predisposed to sexual contact transmission. There are going to be certain organisms that are so well adapted to these tissues and this mode of transmission. They're used to having a steady supply of nutrients from their host, that they don't survive well in resource limited environments. So there will be a couple organisms that are going to be present in the normal flora of the vagina. This will include lactobacillus, streptococcus, especially the group B strep, and Candida albicans, which causes a vaginal yeast infection in some cases. That will be present in 10 to 25% of women on a natural basis. On the men's side, The male urethra is mostly sterile except for maybe the skin microflora at the external opening. And then one other big disadvantage on the female side is you can see here's the urethra, here's the vagina or vaginal opening, here's the anus. So there's very good likelihood of cross-contamination between the fecal matter and the urinary tract opening and the vaginal cavity opening. So those are definitely going to be a concern. On the men's side, you don't have that because the anus is way back here and the penis protrudes from the skin. There's just proximity-wise very little chance of that fecal cross-contamination. Okay, so with the urinary tract infections, there's really only one, and it's a urinary tract infection. This is mainly going to be caused by opportunistic pathogens. Almost all are bacterial. We just talked about the bad side of being female. You're 8 times more likely to develop a urinary tract infection than a man because of that proximity. But sexually transmitted infections, or STIs, can also affect the urinary tract. So we're going to go through a couple different terms. Urethritis, you'll see a lot. This is inflammation of the urethra. Cystitis doesn't, so most of these words kind of tell you what it is. Cystitis does not. This is an infection of the urinary bladder. So we're talking about a bladder infection in this case. Ureteritis is an infection of the ureters. And then pyelonephritis is a kidney infection. So we've got some curveballs here. Now, cystitis, which is, again, that bladder as well as lower urinary tract infection, is very common among women. Again, they do have a shorter urethra than in men, and it's much closer to the anus. So for that reason, most of these are going to be due to E. coli, about 85 to 90%. A secondary, or not secondary, but a second type of organism that could be at play here is Staphylococcus saprophyticus, which accounts for 10 to 15% of these infections. We see 7 million new urinary tract infections in the US per year. 900,000 of those are hospital acquired, often with a urinary catheter. The symptoms of this, if you've ever had one, you know full well how to describe it. It's one of the most painful things ever. It's characterized as this dysuria as well as pyuria. So with dysuria, this means that there's difficult, painful, urgent urination. It feels like you're peeing fire. And then pyuria, which is pus in the urine. So we'll see both of those things. For diagnosis, this relies on sheep blood agar or McConkey agar, and we use a calibrated loop. And the reason for this, it will only pick up 10 microliters, for example. When you streak that on a plate, because you know how much you collected, based on how many colonies you see there, you can make an estimate in terms of how many colony forming units are present in the urine specimen. And that's important because anything above 100 CFUs per mil is diagnosed as a urinary tract infection. That's a positive. Urinalysis is also helpful. It will show an elevated leukocyte esterase, or LE, result that indicates active infection. Thankfully, this is treatable with antibiotics. However, resistance is becoming a significant problem, and especially with those hospital-acquired varieties where those organisms are exposed to antibiotics on a regular basis and have greater opportunity to develop that resistance. Now, if you leave something like this untreated, not only are you going to be in terrible pain, but 25% of these cases will advance to pyelonephritis, which is a kidney infection, which is a bit more serious. So pyelonephritis is when you have that inflammation of one or both kidneys. Its symptoms will include fever, flank, and or back pain. The etiology of this is most often E. coli, about 75% of cases. Complications that go with this include bacteremia. You could have a septic infection, as well as chronic infection that can develop in the kidney, causing scar tissue, which will impair their function. And this can potentially be life-threatening. Diagnosis is going to depend on blood culture, as well as a gram stain of the urine. So we'll define it kind of in the same way as we do for urinalysis or urinary tract infection. But this time there's a greater burden of proof here. The urine culture needs to show greater than 10,000 CFUs per mil and a positive LE test from urinalysis. Treatment-wise, this is going to require IV antibiotics, and you'll treat this empirically, meaning with a broad spectrum antibiotic. You don't exactly know what you're working with yet until you get an ID and antimicrobial susceptibility data back from the lab. At that point, you can refine the treatment. Perhaps you find that the empiric treatment is unlikely to be useful because the organism is resistant. You can change course at that time. So again, there really isn't a whole lot going on in the urinary tract infections. They're very common, but there's really not a lot of diversity there in terms of the organisms that can and the types of infections you can see. There's a lot of variability here in the reproductive side. So for the bacteria, we're going to look at gonorrhea as well as non-gonococcal urethritis, which is usually chlamydia. Pelvic inflammatory disease, which is sort of a complication of many of these diseases. Syphilis, and LGV, I think we actually cut out. I don't think that's in there. We do talk about chancroid, and we do talk about bacterial vaginosis. All right, so gonorrhea is caused by Neisseria gonorrhoeae. So Neisseria is a relative, same genus as what causes meningitis, Neisseria meningitidis. It's a gram-negative diplococcus. That's very key when you look at it under gram stain. It's pretty easy to tell. And it tends to be a co-infection with Chlamydia trachomatis. So these two seem to go together. They have a very similar pathogenesis. Epidemiologically, 60% of the patients that are affected by this will be young and sexually active between the ages of 15 and 24. With men, in a single unprotected exposure, you have a 20 to 35% chance of infection. For women, when you don't know, but perhaps we do know that somebody is infected with gonorrhea, a single unprotected exposure is going to have a much higher risk of infection, 60 to 90%. For pathogenesis, this organism uses fimbriae. Remember, those are those hair-like projections on the outside of the cell. They use these to attach to the epithelial wall. From there, they invade the space that separates the columnar epithelial tissues, cells, and then from there they can go systemic, causing things like gonorrheal endocarditis, meningitis, arthritis, and infections of the eyes and pharynx. So we do have this throughout the United States, except for maybe in Montana, Wyoming, Utah, and Idaho. Not really a problem in Puerto Rico either, but we do have a higher incidence here in the Southeast. So we definitely want to be on the lookout for this. Now, we used to see, if we look at the rates of infection over time, you'll see we had an early spike in the mid-40s. This is part of the baby boom, yay. And then it dipped, mostly with the advent of penicillin, honestly. And then we saw this big spike in the mid-70s. Any ideas why that is? The advent of oral contraception. So with this, people thought, oh, I can't get pregnant anymore, so I don't need to use any sort of barrier protection. So I can just have sex all the time. And without any protection, really, on a barrier side of things. And unfortunately, that's not true. You still need that. So as that education became more prominent, you see these numbers decline. And so now we have a lower rate, but it's still higher than I think anybody would really like. The symptoms of gonorrhea are going to include inflammation as well as pus. On the men's side, it's going to include painful urination as well as a pus-filled discharge from the urethra. Usually that's enough to terrify most men. They're going to go to the doctor. Symptom onset can take place in 3 to 5 days. Complications of this, if left untreated, include urethritis and epididymitis. Now, let me see if I can go back to what that is, because some people don't know what the epididymis is. But it's really, if we look at this term right here, it's talking about this structure that sort of, where'd it go? It surrounds the testes. So that's what we're looking at here. So you're going to see an inflammation of that. Let's go back to where we were. Okay, for women, this is going to be harder to spot. The symptoms are a lot more are nonspecific, and some of them are going to be asymptomatic. Usually only the cervix is infected, and how often is that cervix really looked at? Not often at all, except for the annual pelvic exam or if you have a comorbidity that you need to get checked out. So complications of this on the women's side is something a bit more serious. You'll see abdominal pain, and this is associated with pelvic inflammatory disease. This is a bit more of a chronic condition where you're having this constant inflammation of the pelvic organs. We'll talk about this in a bit more detail in a little bit, but just be aware that this is something that is hard to see, but eventually very problematic. And then you can have pharyngeal gonorrhea. How do you think you get that? You guessed it. It's going to look a lot like strep throat. So that's going to make it a little bit hard to diagnose. But if you do have a patient who looks like they have strep throat, but then the rapid strep comes back negative, if they're a young person and sexually active, it might be a good idea to test for gonorrhea as well, which can lead to very uncomfortable conversations with parents. But there it is. All right, so transmission of gonorrhea, there's any kind of sexual contact. So this can be affecting the throat, the anus, the penis, the cervix, you name it, people have found a way to have sex with it. So there's that chance of infection there. You can also have hand to eye in transmission. So let's say you're a gentleman, for example, and you see that pus coming out of your urethra, and obviously that's kind of terrifying. And you touch the pus because you want to get a closer look at it, and you accidentally jab yourself in the eye. Well, you've just given yourself an eye infection with gonorrhea, which does not sound like a good time to anybody. Another thing that you can get with babies is going to be ophthalmia neonatorum, which is a vaginal transfer of gonorrhea to the baby during delivery, and this can result in blindness. Now, usually, we're going to know if mom has a gonorrheal infection because one of the early stages of their OB care is going to be a big panel testing for a lot of these, as well as a pelvic exam. So you would see that inflammation of the cervix potentially. So we can treat with antibiotics if we know this is going to be an issue. We can also consider something like a C-section to avoid that cross-contamination. But we do treat all babies with antibiotic ointment for their eyes because of this risk. So diagnosis, and men, you're going to be looking at a gram stain or a stained smear of the pus from the urethra, and you should find diplococci. So if we're looking at, these are leukocytes, so white blood cells, and you'll see, it's hard to tell here, but these are diplococci. They're two little circles right next to each other. In women, you're going to culture from the cervix on special media. This will probably be a swab that you then send to the lab, and they will grow this on a special media. It's very hard to grow. It's one of those that's really well adapted to living in the reproductive tissue, and it doesn't grow nicely in the lab. You can also do an ELISA test, which is an antibody test of the pus or cervical swabs, and this gives results in about 3 hours. So this is obviously preferred compared to culture. And then lastly, we have DNA-based testing to give you a rapid and very specific diagnosis. In treatment, resistance is a big problem. In fact, just recently, it's made headlines that we now have gonorrhea strains that are resistant to all of the common first-line treatments for gonorrhea. So that sounds like a bad day. So when we are able to treat, though, we want to treat sex partners in addition to the person that we're seeing in the clinic to help reduce the risk of reinfection and to treat any asymptomatic females that those partners might also be having sex with. So that's going to be kind of the responsibility of your public health department. Gonorrhea is a mandatory notifiable disease. So they will do the legwork there a lot of the time of contacting the individuals who are having sex with the people that you are seeing there in the clinic. The next disease we're going to talk about is chlamydia. This is caused by Chlamydia trachomatis. With symptoms wise, it's going to present in some ways very similarly. You're going to have a painful urination, however, with a watery discharge with many asymptomatic carriers. So we're going to have a discharge here and it's going to be watery as opposed to pus filled on the men's side. So complications of this, just like with gonorrhea, you can have pelvic inflammatory disease that develops in females. You can also have eye infections. This is called trachoma. You can also have pneumonia in babies who are exposed to this in the birth canal. And there's also an increased risk of cervical cancer associated with this, but it's unclear whether this is due to co-infection with human papillomavirus or HPV, or if chlamydia on its own is encouraging that. And on the men's side, you can also see epididymitis as well as sterility. Okay, the pathogenesis for this is virtually identical to gonorrhea, so it is able to go. It is able to go invasive. It is able to enter the bloodstream and target lots of tissues, in addition to the reproductive tract. Okay, the diagnosis for this includes culture, which is very, very slow. On the other hand, you have DNA or RNA-based tests that are very fast, but very expensive. So from a clinical standpoint, you're most likely going to be sending this to a centralized clinical laboratory, like not Quintiles. The words are escaping me right now, but you know who they are. You're going to be going to one of those most likely. Most clinics will not be able to do this right there in the clinic. Prevention-wise, we want to routinely screen sexually active women who are under 25 years of age. So this would mean at every single pelvic exam that they have, you test for chlamydia, because there is that high risk of pelvic inflammatory disease with asymptomatic carriers. And so even if they're not, maybe they're married, for example, and they don't think that there's a risk, go ahead and test anyway. And in fact, I know on military bases it's required by law. They have to. All right. Other high-risk groups are also going to need to be immunized, or not immunized, but treated and screened for this. So this would include people engaged in prostitution. Really, that's the big one that I want to mention there. Treatment for this is going to use antibiotics, and resistance so far is not a problem, but you know life always finds a way. So it's potentially problematic in the future. Okay, now we're going to dig in a little deeper to that pelvic inflammatory disease, or PID. Really, this refers to any extensive bacterial infection of the female pelvic organs. This can include the uterus, the cervix, the uterine tubes, or the ovaries. Some complications from this include infertility as well as chronic pain. So even if you're not showing pain, you could be slowly becoming infertile, and that's not something you want to do once you find out that you're really ready to have kids. You can have something called salpingitis, which is infection of the uterine tubes, and this is the most serious form of PID. You can develop scarring that will block the passage of the ova from the ovary to the uterus, and this will contribute to sterility. This scar tissue will also increase the risk of an ectopic or tubal pregnancy. So when that egg is fertilized, rather than implanting in the uterine wall, it will migrate up to that uterine tube and embed itself there. Its etiology is polymicrobial, meaning it can be caused by many different things, but the most common are Neisseria gonorrhoeae and Chlamydia trachomatis. There are few, if any, symptoms associated with this, especially if it's happening with gonorrhea, but the damage can be even worse if it's with chlamydia. So it's important to do that screening at every single pelvic exam. Prevention-wise, we want to encourage the use of barrier contraception with spermicides. Oral contraceptives are not going to be enough. Diagnosis is going to need to include signs and symptoms, including infertility. Often you might have patients that will come in and say, you know, we've been trying for over a year, we haven't been able to get pregnant. Then you do the test and you find out that they have this, and there's little you can do for them at that point. Some will have pain. But otherwise, the biggest thing is going to be positive culture from the cervix during their annual pelvic exam on the women's side. Prevention-wise, that's a duplicate, so sorry. But we can treat this with antibiotics. It's just really important that we get to it early before that scarring takes place in the uterine tubes. Okay, we're going to move on to syphilis. This is caused by a spirochete. That's a gram-negative called Treponema pallidum. It is, as a spirochete, it's motile, so it's a swimmer. It's unable to do a lot of its own biosynthesis, and so for that reason, it depends on the host to do a lot of its like building proteins or building the amino acids to make proteins, for example. It's not going to survive well outside of the body. In fact, culturing this is very, very difficult. Pathogenesis-wise, the disease itself with this is going to be mainly caused by, or triggered, by inflammatory lipoproteins that the organism produces, which then, as the name suggests, triggers that inflammation from the immune system. From there, once we've made the bloodstream good and leaky, we've draw on those inflammatory mediators to increase the permeability of the blood vessels, the organism is then going to jump into the blood and as well as cross junctions between cells. Its incubation period is about 3 weeks. And this disease can be seen in various different stages. It can also go latent. So we'll talk about that. Transmission, much like for gonorrhea and chlamydia, is through any sexual contact. It doesn't matter which orifice we're talking about. At-risk populations for this are going to include inner city residents, drug users, as well as prostitutes. Okay, this is primary stage syphilis, the first of a few pictures. I tried to limit it as much as possible. The signs and symptoms of this are going to include a chancre, which appears 10 to 90 days post-exposure. It will disappear on its own in a few weeks. In women, it will be on their cervix, so they most likely will not know it's there unless you happen to spot it at the right time during a pelvic exam. In men, it's going to appear like it does here in the picture as a small, hard, painless lesion, but it will have this exudate coming from the center, sort of like a pus, that's infectious. So if that contacts with the skin of a female, then it can transmit. In men, though, it can sometimes form on the inside of the urethra, and because it's painless, they might not know it's there. The bacteria can enter the bloodstream from here, and as well as the lymphatic system. And as you could probably tell, a transmission of this is going to be sexual. Secondary stage syphilis is a progression where we now see a rash on the skin, kind of looks like this. It looks a little bit like vesicles, like we would see with chickenpox. It's visible, though, on the palms and soles, too, which you don't normally see with chickenpox. It will also be accompanied by hair loss, malaise, mild fever, and neurological symptoms, although these are rare. Ordinarily, this can resolve on its own in 3 months, but there will be a certain amount of people that it will progress even further beyond this. Now, these lesions that you see in the rash, they contain many spirochetes inside them. So if you're itching those and you open the wound and then you touch something, you are maybe unknowingly transmitting that. It's very infectious at that point. The damage to the host is due to the inflammatory response as well as immune complexes that your immune system will develop antibodies that'll bind up syphilis, but it's not really able to clear it at that point. So instead, you get these complexes that form, and they can be rather large, and they can lodge inside of a capillary or various body sites and impede blood flow, which can be very damaging to the tissues. Its transmission includes sexual contact as well as non-sexual at this point because of those vesicles. So the at-risk people in this case are going to be dentists because it'll show on the mucosal linings, and healthcare workers who are looking at that, trying to understand what it is until you get the lab report. Wear your gloves. At this stage, the syphilis infection can go latent or dormant. So those, let's see. In latent syphilis, there will be no symptoms, and this stage can last 2 to 4 weeks. During this time, it's no longer infectious unless you are pregnant during this time, and that will be called congenital syphilis. If that happens and it crosses that placental barrier, it can affect mental development as well as causing other neurological symptoms in the developing fetus. The majority of cases of syphilis will not progress beyond this latent stage, even without treatment, but life always finds a way, and syphilis does too. We can also have tertiary stage syphilis. At this point, if you haven't seen a doctor, it's time. And so this disease, what's going to happen here is it's gone latent and it's going to reappear. But it's going to reappear many years later. So you think you've gotten over that infection, right? And it wasn't that bad. You had a rash, but it went away. But 20 years later or so, this comes back in about 25% of untreated cases. The symptoms are going to be, again, mainly due to the immune response and their ability to, and to the surviving spirochetes that were able to sort of hide out. So we can have this in 3 forms. You can have gummatous syphilis, where these gummas form, these lesions, they're huge. And these are progressive inflammations that appear as rubbery masses of tissue. And this can appear after, like I said, 15 years or so, so a long time. You can also have cardiovascular syphilis, which is a weakening of the aorta. Thankfully, this is a lot less common now with the advent of antimicrobial therapy. And then one of the really interesting complications here is neurosyphilis, which will be associated with all sorts of neurological symptoms, including personality changes, seizures, dementia, the inability to coordinate voluntary movement, a partial paralysis, loss of bladder and bowel control, etc. This will occur in 10% of untreated cases. Thankfully, it's very rare in the modern era. We tend to catch it before it gets to this point now, but that didn't used to always be the case. Okay, so for diagnosis, it's going to require visual microscopic inspection, but unfortunately, and this was really the only thing that will work during the primary stage. So if you're able to get some of that exudate from the penile lesions, you can do it that way. Serological tests can help too, but this is only really going to be possible during secondary and tertiary stages because it takes about 3 to 4 weeks for you to develop antibodies in a full immune response. So we can't test before that happens. We also have rapid diagnostic tests that require something as simple as a finger prick blood sample, which you can do in the clinic. So that is probably where you're going to see most of your stuff going on. That and the microscopic inspection. Treatment for this involves a variant of penicillin that's injected. And you get one dose and it lasts for about 2 weeks, and that's usually enough to kill these off. We also have alternatives for those who are allergic to penicillin. Next, we're going to move on to bacterial vaginosis. This is not a yeast infection, which is what you were probably thinking of when you saw this. No, this is caused by an organism called Gardnerella vaginalis. This is usually going to be something that it's an opportunist. So it's going to require that something happened to the lactobacillus population, which is going to give Gardnerella a competitive advantage. So when that pH range increases, normally it's about 4.5, but let's say it gets up to 6 or 7. Well, those are ideal conditions for Gardnerella. So this is going to be something that disproportionately affects women. There's no real presentation of this in men, but the bacteria can live in their urethras, and so therefore this could be sexually transmitted. But on a diagnostic level, you're going to see, you're going to test the vaginal pH and find that it's above 4.5. There will also be a copious, meaning plentiful, frothy vaginal discharge. The secretion itself can have a fishy odor, especially when mixed with a potassium hydroxide solution that you should have in the clinic. And then you can also look at these microscopically and see the cells in the discharge along with sloughed epithelial cells that are coated in biofilm, meaning that there's cells all up around the edges of this. So those are called clue cells. This has some role in premature as well as low birth weight babies if mom is infected during pregnancy. And it can be treated with metronidazole. You're going to see that drug a lot as we go through this. Next, we're going to move into some of our viral infections. This is genital herpes. It's caused by herpes simplex virus 2. It has a 1-week incubation period, and at that time you're going to see these lesions that appear, and it's going to be accompanied by a burning sensation, then vesicle formation, painful urination, but this can ultimately resolve in about 2 weeks. It is transmitted by contact with those vesicles through semen or direct contact skin to skin. You can also get a variant of genital herpes simplex virus 1 infections due to oral genital contact. So remember, the HSV1 causes cold sores and fever blisters. And so if you're having oral sex at that point, you're going to have contact between the mucosa that normally has HSV1 and what can normally house HSV2. Well, it turns out they're similar enough that HSV1 can live on the genitals as well. And this is actually what accounts for about 50% of US cases of all genital herpes infections now. So keep in mind that condoms may not be enough on a lot of these, because in women, their vesicles may not be on the external, in women, their vesicles are going to tend to be external. And for men, it's often at the base of their penis. So these are two tissues that are, or especially that the base of the penis thing is just from a mechanical standpoint, not going to be protected by that condom, for example. So this virus can develop lifelong latency in nerve cells, kind of like HSV1 will do to cause cold sores. So for that reason, it can be reactivated and you can get recurrences. These tend to happen more often in men than women. And it tends to be skewed more heavily towards those who are infected genital herpes-wise with HSV2 as compared to HSV1. Diagnosis of this is going to include signs and symptoms, culture, cell culture, for example. We can do DNA-based testing and serology. This can be managed with antivirals, but it can never truly go away. We can't cure it because of its latent stage. A variant of this is neonatal herpes. This happens when the virus crosses the placental barrier, causing spontaneous abortions or fetal or serious fetal damage. If left untreated, this can result in a 40% mortality, and even those who have been treated can have significant disabilities. The transmission of this is most likely to occur if mom is initially infected during pregnancy. Now, if she's in her latent stage during pregnancy, there's a lesser risk of this being an issue. If she's having a recurrence during pregnancy and especially close to delivery, that's pretty common because, again, she's going through a lot of stress and that can reactivate the virus. So you may have to consider something like a C-section in those cases to avoid that transmission. It can also, like I mentioned right there, be transmitted during vaginal delivery, and this is actually the majority of cases. When this happens, about 30% of those cases will be associated with damage to the central nervous system, resulting in some of those same problems that we saw before, but now including things like blindness, hearing loss, epilepsy, and death. Okay. Genital warts. I did not show pictures. You're welcome. This is caused by papillomaviruses, and there are over 60 different kinds. They really like the mucous membranes. So you'll find that you can have papillomaviruses that infect things like the sinus cavity, your vaginal tract, all sorts of things. The transmission here is sexual contact. The incubation period is a few weeks to a few months. In men, it's very hard to see. The penile lesions are often flat, and so this innocuousness that you don't see it can aid in transmission because they will continue to have sex, potentially spreading it to others. Human papillomavirus is associated with cervical cancer. It kills about 4,000 women annually in the United States, and it's also attributed to oral, anal, and penile cancers. This is one of our most recent vaccine success stories, though. The vaccine, there is a vaccine, 2 formulations that are available, and it's recommended for children ages 11 to 12 before they become sexually active. And we do recommend this for boys as well as girls because of that risk of oral, anal, and penile cancers as well. It also helps to prevent transmission to the women of their lives in the future. Now, what's interesting is the vaccine itself induces a stronger immune response than natural infection. So let's say you do have an infection naturally and you overcome it, you're not going to develop lifelong immunity to it. But there's a greater chance of that happening with the vaccine. Treatment-wise, we can reduce this, but we can't cure it, unfortunately. We can use things like gels and interferon, which is one of the mediators of your immune response that kind of works in an antiviral fashion. But again, we can't get rid of this. 90% of the cases can clear spontaneously in about 2 years in terms of outward symptoms, but the virus will always be there. Okay, HIV/AIDS is something we're going to do a hop, skip, and a jump through because it's actually more of an immune system disorder than a sexually affected disease. Sexual contact is one way for it to be transmitted, but in and of itself, that's not really where its activity lies. Its etiology is the human immunodeficiency virus, which is what HIV stands for. Initially, you're infected with HIV. You have a slowly developing disease that can be transmitted by exchange of certain body fluids. So we mentioned the sexual contact. It's important to note that you cannot get this from saliva, tears, or sweat. So there's that. Pathogenesis usually involves a systematic takedown of the immune system. So we'll be coming back to this. during the lecture about the immune system. We're almost to the end, guys. All right, so for the fungal infections, we're really going to talk exclusively about candidiasis, which is a vaginal yeast infection. If it happens in the mouth, then this is called thrush. Thrush tends to happen a lot in babies. It can also happen in the elderly and people that have been treated with antibiotics. The etiology for this is 90% of the time Candida albicans, but there are other species of Candida that can result in that other 10%. Pathogenesis-wise, this again is an opportunist. It's something that's in the normal flora of the vagina, but when the pH of the vagina rises due to the diminishment of lactobacillus or other factors, you can get this opportunistic overgrowth. And when that happens, you'll see things like a severe local itching, as well as a thick, yellow, cheesy discharge. No pictures. And this can come with or without a yeasty odor. So you can see the pictures of oral thrush here, because I did want you to see that, and at least we're not looking at some of these vaginas, so there's that. But you can see that it doesn't look anything like strep throat, for example. It's got a very clear appearance. Let's see. The risk factors for this include the use of oral contraceptives. Pregnancy itself will change the pH of the vaginal tract. Uncontrolled diabetes, again, anything that's messing with your hormones and therefore potentially messing with the pH of that location. And then antibiotic treatment, anything that's going to wipe out lactobacillus. Diagnosis of this is going to rely on symptoms as well as microscopic identification of the organism. You take a scraping, basically, of what you see there and look at it under the microscope. You can also send this for culture. It grows on the same kind of media as what we use for bacteria. Treatment for this is going to include over-the-counter medications that they can get without a prescription, as well as single-dose prescription antifungals. Diflucan is the trade name. Okay. I think this is our last one, trichomoniasis, which is a protozoan infection that affects mostly young, sexually active women, resulting in about 8 million cases per year in the United States. This is caused by an anaerobic protozoan, which is called Trichomonas vaginalis. It is normally, or it can normally be, an inhabitant of the vagina and the urethra in men. It doesn't usually present on the men's side, only in the women. It is sexually transmitted, and often it goes alongside with gonorrhea. Like yeast infections, this is again an opportunistic overgrowth due to elevated vaginal pH. You'll see leukocytes accumulate at the infection site, and so this will be part of your diagnosis, is seeing those white blood cells when you look at the discharge. The symptoms will include a profuse greenish yellow discharge with a foul odor, along with irritation and itching. About 50% of these cases, though, you won't see any symptoms, but it can cause pretty significant complications, especially in a pregnant mother, including things like preterm delivery, which can correlate to low birth weight babies. Diagnosis is going to involve microscopic examination of the discharge, the symptoms, if they're present. Culture media can be used, and DNA-based testing. Treatment for this is going to involve oral metronidazole for both partners. So we don't want to just treat the female and understand that if maybe she's in a committed relationship and the gentleman has this naturally in his urethra, she's going to be repeatedly exposed. So we want to try to treat it in both partners. So here are some review items for you, especially things like how do you tell gonorrhea and chlamydia apart from one another, because they often are going to be transmitted together and they can kind of mask each other. So how are you going to tell them apart? Make a list of all of the diseases that are dangerous to a developing fetus. We talked about several. And why are urinary tract infections more common in men, or in women rather than in men? So make sure you can get through those. Don't forget also that we have the differential diagnosis presentation that goes along with this. It's available to you on D2L. So that wraps up our tissue by tissue survey of the different infections of the human body. From here on out, we'll be talking about the immune system. Thank you.